Okay, so welcome everyone to the December Jousse Lecture. It's my distinct pleasure to introduce our speaker for this Jousse Lecture. That's Lora Giangregorio, and she and I are collaborating on a project together, so I'm happy that she could spend some time to talk about fracture research. And I'm just going to read a quick bio of Lora Giangregorio. She's a professor in the Department of Kinesiology at the University of Waterloo and is the Schlegel Research Chair in Mobility and Aging. She leads the Bone and Health Exercise Science Lab, and she studies how to prevent osteoporotic fractures via risk assessment and physical activity interventions. She has many roles, including a membership of the Scientific Advisory Council for Osteoporosis Canada, with whom she collaborates on initiatives to improve patient and healthcare provider education that's related to physical activity and exercise. She was also on the leadership team that developed the Canadian 24-hour movement guidelines and is leading the exercise working group for updating the Osteoporosis Canada clinical practice guidelines for the management of osteoporosis. The title of her talk today is Applying Exercise Science to Prevention of Falls, Fractures, and Frailty. And she has told me that we will leave all the questions till the end of the talk today. But if you do have questions along the way, feel free to put it in the chat, and then we'll gather them together at the end to go through them. So Dr. Giangregorio, welcome, and we look forward to your talk today.
Thank you. I want to thank you also for inviting me. I'm really excited to present today, and hopefully there's some new info for folks. And I'm just going to start with, sort of what grounds the work that we do. And it's often the questions that come from patients or from clinical practice, sometimes from healthcare providers. And, I frequently, every time I do these talks for Osteoporosis Canada and do them for patients, we get all kinds of questions. In fact, the last time we did an online talk, we asked people to submit questions in advance. We got like hundreds of questions, and I went through them, and there's two main themes. It's like, is X safe? Like, this thing that I want to do, is it safe for me to do? And these are people with osteoporosis. And the other thing is, what should I do for X? Like, if I want to improve my bone density, if I want to improve my posture, if I want to, prevent falls, that sort of thing. So these are the kind of key themes that end up coming out when we start looking at patient questions. And unfortunately, as researchers, we don't always think that way. So as researchers, we often have kind of a pet hypothesis or a thing that we're really interested in understanding. And sometimes it's like the association between X and Y, or, that sort of thing. And while those are important questions, especially to understand sort of the fundamental nature of bone health and that sort of thing, we also need to think about designing really good questions, and especially when we go to guidelines, right, in terms of management, is you want to equip healthcare providers with the answers to the questions that patients are going to ask. So we need to think carefully about, how often we're distracted by our pet hypotheses versus also understanding the patient's perspective in designing our research. And you can do both. It's not to say there's something wrong with having the pet hypotheses, but the idea that you also think about making your research important for, especially if you're doing clinical or translational work, is what do patients actually care about? And that can come out in the questions you ask, it can come out in the outcomes that you assess, or just the way you translate the research. So I think that, we started this work in kind of coming up with guidelines and recommendations for fall and fracture prevention many years ago with this underlying principle, in that there were a number of studies to try to understand the effects of exercise on bone density and fractures and that sort of thing. But when we did a focus group with patients to ask them, what's important to you, they said, well, a fracture is important, but what's really important is the effect of the fracture on my life. So if I, when I had my spine fracture, I couldn't, do my dishes or my groceries, and I felt a bit useless. And so that function was the problem. And so it caused us to think, wow, we really should start thinking about functional outcomes in our clinical trials and not just, does it have an effect on bone density? So that's a good example. And so we did this process called Too Fit to Fracture, where we went through all of the evidence around the effects of exercise on a bunch of different outcomes, and we got patient input on the outcomes, like I mentioned. And then we took all the questions that were frequently asked by patients, we took a list of them, and we did a Delphi consensus process to try to come up with answers to those questions. And what emerged from that was a consensus on both exercise, which is planned, purposeful, with the intent of improving health, as well as physical activity recommendations. So any physical activity that a person does where there's movement and it creates that energy expenditure. So, me going to the gym to lift weights is considered exercise because I plan it and I'm doing it for a specific goal. Whereas, me going for a walk with my friend is physical activity because I'm doing it mainly because I'm moving, I'm expending energy, and I'm interested. You can go for a walk for exercise, but physical activity like me doing dishes, that's physical activity. And so people often have questions about physical activities they do, like, can I lift my grandchild? Can I golf? Can I, is it risky for me to do gardening? Those sorts of things. So we need to be able to answer those questions. So this process tried to help answer some of those questions. And we did a knowledge dissemination initiative with Osteoporosis Canada, which was funded by the Ontario government. And that was really exciting because it allowed us to take the recommendations and then develop videos for patients, educational resources for healthcare providers, other resources for patients. And we went all over Ontario doing presentations and knowledge exchange. And that was really exciting. And I'm really fortunate to be able to partner with Osteoporosis Canada on this. But from that process, we learned a number of barriers that people experience. And also that, research does continue to emerge. And so we have to revisit guidelines. And so we do have new guidelines coming out. And these lovely individuals are people I'm collaborating with on the exercise guidelines. So Osteoporosis Canada is doing new osteoporosis management guidelines that will address risk assessment, medications, exercise, and nutrition. So I'm leading the exercise working group, and these are the folks that are working with me. And so new guidelines are coming out. I can't release what they are right now, but I will talk about the research that we've done to date and the findings of that research that will inform the guidelines. So you'll get a sense of what direction we're going in. But before we did that, we started with a survey of patients. And again, grounding our work in what is important to patients. So we did a survey of 1,100 members of the Canadian Osteoporosis Patient Network to ask them things that they wanted us to consider in the guidelines, the types of outcomes that were important to them. And so, and also we had some open-ended questions about what they were interested in understanding, and specifically what questions they have about the safety of exercise or physical activities of daily living. And so when we asked them what outcomes are important to you, the ones that came out as sort of the top or most important are quality of life, preventing death or long-term care admission due to fractures, their ability to do daily and social activities, fractures, and side effects. Side effects pertaining primarily to medications, but also harms associated with physical activity. And then when we ask them, what questions do you have about the safety or effectiveness of exercise, physical activities of leisure, or daily life, the types of questions, again, kind of fit under like, what should I avoid? What is safe for me to do? And then, what is yoga safe? Is doing, is trampolining safe? I get that question a lot, actually. There's a remarkable number of people who want to do trampolining, like little jumping on those little trampolines, but they would mention specific activities and ask if they were safe. But then they would also ask, what is the most effective exercise for X? Other questions that came out around implementation. So how do I get access to trained professionals? Or I can't afford this, so where can I get information on the types of exercise that I should be doing? And then they had specific questions again on certain outcomes, like the effects of certain types of exercise on bone density, fractures, balance, strength, pain, and quality of life. So that helped us understand the direction that we wanted to go. And so because of that, we included a variety of questions. So we started our question with, should we recommend exercise compared to no intervention in men and postmenopausal women aged 50 years and older at increased risk of fracture? And I will replace, we did basically 7 questions. So should we recommend walking? Should we recommend, and walking or Nordic walking? Should we recommend impact exercise? Should we recommend balance and functional training? Should we recommend resistance training? Should we recommend yoga? Should we recommend Pilates? And then also we did another piece on the efficacy or effectiveness of exercise for hyperkyphosis, or an exaggerated thoracic kyphosis or curvature in the upper back. So rather than kind of looking at exercise broadly, we went specifically at these types of exercise, because we now realize people want to know what is the most effective exercise for certain things, and also what are the harms of specific types of exercise. So the distinction between the Too Fit to Fracture process and this one is that we did a sort of specific deep dive on each, what do we know about each type of exercise. And so that was where we started. So that required 7 systematic reviews, which are now complete, and some of them are published. And the reason we took this approach this time is that we know in exercise physiology that the training responses or adaptations are tightly coupled to the mode, frequency, and duration of exercise that is performed. So it may be that, you know, if we want to prevent falls, we might need to do a certain type of exercise. But if we want to improve bone density, we might need to do a very different type of exercise. So we need to look at the types of exercise separately to be able to really answer the question, you know, what type of exercise should I do for X goal that I have? And also understanding the safety of different types of exercise was really important to patients. So we divided it by type, but we also looked at different outcomes. And again, thinking about, you know, what are the outcomes that are important to researchers versus what is important to patients. And what tends to come out with patients is things like physical functioning, quality of life, premature death, as well as fractures and adverse events. So the outcomes that we used for our systematic reviews were fractures, death, falls, muscle strength or physical functioning. We couched it as physical functioning rather than muscle strength. We looked at bone density only when there wasn't good fracture data, which was most of the time, but we didn't have a lot of, most of the studies didn't have enough, weren't large enough to look at fractures or didn't record fractures. We also looked at, so bone mineral density was sort of a proxy or surrogate outcome. We also looked at quality of life. And then for the systematic review where we were looking at the effects of exercise on hyperkyphosis, we also looked at posture and back extensor strength, because those are specific outcomes related to that type of exercise. People want to know, what type of exercise should I do for posture if I have a curved spine? And so we looked at, you know, what was the effect on, you know, spinal curvature and back extensor strength for that review only. And so if we start with fracture as an outcome, there was really only one type of exercise where we could make any meaningful conclusions. And so there is some evidence that gait, balance, and coordination or functional task training, so balance and functional training essentially is what we shorten it to, can reduce fall-related fractures by 56% compared to control. However, this is low certainty evidence. There are not a lot of studies, and there are some issues with the studies. So we said there's low certainty evidence. So we suggest this type of exercise for the prevention of fractures. We would suggest it because there is some evidence, although it is low certainty. When we look at the other types of exercise like walking, Tai Chi, resistance training, they're uncertain. And this is data that comes from an existing systematic review, so not one that we did. And this is in older adults. So in fact, this isn't in people with osteoporosis, it's in older adults because there aren't enough studies specifically in osteoporosis. However, we could probably argue that the effects in people with osteoporosis would be similar. Like we'd be able to generalize these findings to people with osteoporosis. It's quite likely that this type of exercise would also prevent fall-related fractures in this group. So, so that's really exciting. We're able to kind of get a sense of what types of exercise would prevent fractures. And then if we think about what types of interventions prevent falls, again, we go to the Cochrane review by Kathy Sherrington's group because they are very comprehensive assessment of all of the studies looking at the effects of exercise on falls. And they did analyses specific to the type of exercise. So the types of exercise that were shown to prevent falls are multi-component exercise programs. Often these are programs that combine balance, functional, and resistance training, and they reduce the rate of falls or the risk of being a person who falls. The rate of falls by 34% and the risk of being a person who falls by 22%. And this is moderate certainty evidence. balance and functional training alone reduce the rate and risk of falls, and this is high certainty evidence. And Tai Chi also reduced the rate and risk of falls. Low certainty evidence for rate of falls, high certainty evidence for risk of being a person who falls. So these are the types of exercise we'd want to recommend for people who are interested in preventing falls. Now, falls is a really important outcome when it comes to people with osteoporosis, because the vast majority of fractures occur due to falls, even fractures of the spine. So prevention of falls is really important and arguably would probably have a significant impact in terms of fracture prevention. The other analyses that Kathy's group did, or Dr. Sherrington's group did, on other types of exercise like walking and resistance training and dance, essentially we can conclude that the effects of these types of exercise are uncertain, or there may be no effect. So if we really want to prevent falls, we need to do the top 3 types, which are multi-component, balance and functional, or Tai Chi. Now, if we look at the types of exercise and their effect on in people at risk of fracture, if we looked at effect on bone mineral density, so it's a table, I'm going to walk you through it. BMD means bone mineral density. And the sites that people usually look at are the spine, the lumbar spine, the femoral neck, or FN, and the total hip, or TH, as in my table. And so what I've done is I've listed all of the types of studies that we looked at, or the types of exercise that we looked at, and I've written the point estimates for the different bony sites. And I will summarize this by saying that the ones that are in bold are the ones where there was a statistically significant effect. The effects in general are pretty small, and the certainty of evidence is usually very low or low. So there is very low or low certainty evidence that impact exercise, either alone or in combination with resistance training, may have an effect on bone mineral density. And I would say that the impact exercise was the one that seemed to have an effect on spine bone density, and the either alone or in combination with the resistance training. And the combination seemed to be the one that might have an effect on hip bone density. And I say that with caution because a lot of the studies combine impact and resistance training. So it's really hard to tease out whether it's the impact training or the resistance training. And there are very few studies. So the largest number of studies was for the combination of resistance training and impact exercise. There were 5 studies. And but still the N is only 209 people across, or 435 or 521, depending on the bony site we look at. So we have basically very low certainty evidence that we may be able to increase bone mineral density with resistance training in combination with impact exercise, and perhaps an effect on those bony sites with impact exercise alone. And one of the studies that is featured a lot is the Liftmore trial. There's actually 2 Liftmore trials, one done in men and one done in women. And these are the findings from the Liftmore trial in women, because that's the only one that compared it to a control group. So the one in men compared it to another intervention. And so the Liftmore trial did high intensity resistance training and impact exercise in healthy women with low bone mineral density. And they showed fairly impressive increases in spine bone mineral density, and a statistically significant, although very small, increase in hip bone mineral density, as well as improvement in physical performance outcomes. I believe it was the time up and go test and the 5 times sit to stand test and a few other measures. So this is an example of a type of intervention that would, if we can get these type of outcomes for BMD, I think patients would be really excited about it. One of the challenges with studies like this is they often exclude people who have fairly significant musculoskeletal issues like arthritis, or if they have problems with disc degeneration or slipped disc, if they have problems with shoulder range of motion, so they can't do the exercises. So quite a few people are excluded from these studies. So one of the challenges is, these are great findings, but there may be it may be challenging to implement them in everybody with osteoporosis. So that would be the one takeaway I would say is this is a great option for some people who can do this type of exercise. We have a study that we're planning. We have a CHR grant to do a study called Finding the Optimal Resistance Training Intensity for Your Bones, or Fortify Bones. And it's a 3-arm trial looking at moderate intensity resistance training, high intensity resistance training, and attention control in men and women with low bone mineral density. And we'll be looking at the effects of, we're going to combine the moderate and high intensity group and compare resistance training to attention control. And then we'll do a secondary analysis looking at the difference between moderate and high intensity relative to control, as well as relative to each other. And we're going to look at, the primary outcome is spine bone mineral density, but we'll also look at hip bone mineral density, body composition, falls, fractures, physical functioning, quality of life, and resource use. That's the one that Brian had said we were collaborating on. I'm really excited about it. We were supposed to start it in the spring of 2020, but obviously COVID happened and that we didn't start. But we're hoping to start it in 2022, although things seem to be changing on a daily basis. And so if we look now at what types of exercise improve physical functioning, again, I've listed all of the different types of exercise in the one side of the left side of the table. And we've chosen timed up and go here as the outcome that is most commonly measured for physical functioning, and there are mean differences listed in the table. And all of the types of exercise had a statistically significant effect on timed up and go performance, except for yoga. There are very few trials of yoga in, actually I think there's very few trials of yoga in people with osteoporosis. The estimate that I have in this table, the standardized mean difference, is actually 5 studies in older adults, is assessed with walking speed. And then the one with Pilates is in older adults because there weren't studies in people with osteoporosis. So there was statistically significant effect on physical functioning for all types of exercise, but the evidence was fairly low or very low certainty evidence. And part of the reason is the effects were quite small. So these are, looking at the numbers, you see that it's around a 1-second difference in performance. So it's not a huge effect. There's also risk of bias and heterogeneity that we need to account. So overall, the effects, there are effects, but they are of low or very low certainty. If we look at what types of exercise improve quality of life in people with low bone mass or who are at increased risk of fracture, there were statistically significant effects on quality of life for all types of exercise except for impact exercise and walking. But there was moderate certainty evidence and a benefit for resistance training, back extensor exercise, and yoga. So those would be the types of exercise, if quality of life was a goal, that I would probably focus on. If we look now at, we did a systematic review on the effects of exercise in individuals with hyperkyphosis. So our target population here was people who had hyperkyphosis or an exaggerated thoracic spine curvature or curved spine at baseline. So, and we restricted it to that because the questions patients often ask are, how can I improve my posture if I have a curved spine due to osteoporosis? And so this is why we focused on, to be able to improve posture, you have to have an impairment in the first place. So we looked at that as the target population. And overall, we found statistically significant effects in back extensor strength, back extensor endurance, kyphosis outcomes, so posture, like the measurement of the curvature of the spine, health-related quality of life, timed up and go, and pain. Again, the quality of the evidence or certainty of the evidence ranges from very low to moderate certainty evidence. But this might be a type of exercise that we might want to recommend for people who are concerned about posture. So people who have concerns could design their exercise program to include exercises for shoulder stabilizers and back extensors and muscles, abdominal muscles that support the spine. So I've got a few examples of exercises that were used in the SHEAF trial, which was a very well done study, probably one of the best. So if you're really interested in this area, I highly recommend you look it up. It's SHEAF, S-H-E-A-F, and the main author is Wendy Katzman, and you can look at the types of exercises that she used in that study, because I would say this is one of the better studies in this area. It's really important for us to also consider harm because there is that possibility that exercise can actually cause injury. And so overall, when we looked at the different types of exercise, adverse events were reported occasionally. So some people experience muscle soreness or pain or minor injuries. So this is a risk that we need to communicate to people. I think it's really important to communicate to people that there may be muscle soreness or there may be these types of things that may happen and what to do about them. Serious adverse events were infrequent. However, the certainty of evidence was moderate to very low certainty, and in most cases it was very low because the reporting was actually abysmal. So adverse event reporting in exercise trials is not methodical, so there's not usually an explicit methods section that explains how they collected the data. There's a lot of missing data. They often don't report adverse events at all, or just say none happened, but we don't know actually how they measured them. So it's really quite bad. So one of my PhD students actually initiated a series of studies looking at the perspectives on adverse event reporting from the perspective of the patient or person, from people who've had injuries during resistance training or exercise, and also from researchers who lead exercise studies. And then she developed a toolkit to support better adverse event reporting in clinical trials of exercise. So she's working on publishing those data. So if you have any questions about that, I can answer them, but hoping that we can work towards better reporting in the future so we have better evidence-informed guidelines. I want to talk a little bit about a subgroup of people with osteoporosis, and it's people who have an osteoporotic vertebral fracture or fracture of the spine. In this group, there is very little evidence, and healthcare providers often don't know what to do. And what's complicated in this group also is that they often don't get diagnosed with a vertebral fracture until quite a while after they've had it. So they so some people will present with severe back pain, go to emerge, and they may be diagnosed with a vertebral fracture, but others might go to their family doctor and say they have back pain, and people might think they just have regular chronic back pain or back pain related to osteoarthritis or other reasons. And so they may not be sent for an x-ray, and they may live with it for a while before coming back and then getting sent for an x-ray or getting a referral to a rheumatologist, and they don't see that person until 3 or 4 months down the road. So it's difficult to identify this group. And then once they are identified, there's not a rehab pathway or care pathway for this group. So, people who have a hip fracture, there's a bit more of a pathway in terms of what you're supposed to do. And then they get rehab, they get sent home, they get some rehab at home, they get home hazard modification, that sort of thing. And people with osteoporotic vertebral fracture, they get often sent home with pain medication and very little guidance other than don't lift anything. So some of the things that are often recommended, anecdotal evidence suggests maybe bed rest, analgesics, bracing, electrical therapies, modified activities. And in the chronic pain group, so people have chronic pain due to vertebral fractures, there are some studies to suggest that exercise might help to address deconditioning and deformity. Or deconditioning, people will also target deformity and work on daily tasks. But the evidence in this group is not great. So I'm going to talk a little bit about some of the work we're doing in this area. So we have some systematic reviews of exercise in people with vertebral fractures, but most of them are people with a history of vertebral fractures, so not in the acute stage. There are some studies of bracing, and there are some informal reviews saying this is what you should do with people with vertebral fractures, but they're based on very little evidence. So one of my PhD students just completed a Delphi consensus process to establish some consensus on the non-pharmacological management of vertebral fractures. So again, going back to the thing, we have very little evidence. So at least let's get some expert consensus on what we should do for people who present with an osteoporotic vertebral fracture, either acute or with chronic pain related to a vertebral fracture. And so we're working on developing kind of a toolkit for healthcare providers to use that has some resources for patients and some, a basic framework for here that's some of the things you can do for the types of impairments that these individuals present with. So we first did several years ago, we did a systematic review looking at exercise after vertebral fracture. And there is some evidence. So there's very little evidence on the effects of exercise on fractures. There are some adverse events that were reported. So people reported fracturing a rib, rolling from supine to prone, or costal cartilage, fracturing a metatarsal, dropping a weight on a foot. There's another fracture that happened during testing. So this is a very high risk group. So it's really important. And interestingly, a lot of the fractures didn't occur during the exercise, but during transitions periods, like while carrying a weight or while rolling, to transition between exercises. So it's really important to make sure that we practice spine sparing, both during the exercise as well as during transitions. There's very little evidence related to the effect of exercise on falls in this group, but we do have some evidence that exercise may improve mobility as measured by the timed up and go. And we also have some evidence that exercise may improve the physical functioning score and the total score on quality of life questionnaires. So we can say with some, there's some evidence to suggest that recommending exercise, especially in the chronic stages, like once the person is healed, might be beneficial for mobility and quality of life. One strategy actually that came out of the Too Fit to Fracture recommendations that we published in 2015 was that we want for pain, we might consider using supine lying, where you actually lie flat with your knees bent, as she has them in the picture, arms out at the sides, not in this picture she's doing an exercise, but just lying arms at the sides. And the idea is to unload the spine and promote extension of the spine and pain relief. And then when the person goes beyond the acute stage and they've healed, they can add exercises for their back extensor muscles. So in this case, she's doing the arm lengthener exercise, where we would hold it for 3 to 5 seconds and kind of reach with the arm and the finger while pressing the shoulders gently into the floor. We did a systematic review looking at the effects of bracing on pain and other outcomes after a spine fracture. And so if you look at the plot here, it seems as if the bracing actually may improve pain after a spine fracture. My only concern is that this effect seems to be driven primarily by the Pfeiffer study that was published in 2004. And I have some major concerns about this work because it was industry sponsored. So it's the only study that showed a statistically significant effect on pain. And they published another study in 2011 where they basically, the numbers they said it was a separate trial, but the numbers are exactly the same. So I'm a little bit concerned, and so I would be really hesitant to recommend bracing based on the level of evidence that we have here, even though the effect seems to be statistically significant. It's also not a huge effect size. So, and there is some risk of bias in the papers that we looked at. So although there are some studies that suggest there might be benefit, I have some concerns. And so I would not recommend it personally. And we have done a consensus on this. And what some people think that using bracing after a spine fracture may help in the initial acute stages to help the person mobilize and have confidence to mobilize. But this is anecdotal evidence. In these studies here, like the Pfeiffer study suggests it might help with pain. So I would say that if you do use them, I would use them with caution and only use them for short periods of time. And you do really need to wean people off them. But personally, my take on the evidence is that I would not recommend them based on the evidence that exists. Some of the challenges and knowledge gaps that we face are that there are few studies in people with osteoporosis. So most of the time we have to lean on indirect evidence in older adults. A lot of the studies have risk bias and poor adverse event reporting, and there's a lot of heterogeneity. So, studies will look at combined interventions like impact plus resistance or functional imbalance and resistance training. And ultimately, many of the interventions are, supervised either one-to-one or in a group in a gym by, physical therapists. And this is a challenge in this population to get everybody access to that sort of thing. So we need to start thinking about ways to design interventions that are easy to scale or spread. So if I had to sort of summarize the tips that I would give in recommending exercise for people with osteoporosis or osteoporotic vertebral fractures. I would start with our existing 24-hour movement guidelines, which are available on the CSEP website if you're interested. These were released in a few years ago, and there are guidelines for sleep and sedentary behavior. So I'd start here. But one of the things with the physical activity guidelines is that they recommend moderate to vigorous aerobic physical activities for 150 minutes a week or more. So 150 minutes is sort of the minimum. They recommend muscle strengthening twice a week and physical activities that challenge balance. And these are the guidelines for older adults. So the ones for adults 18 to 64 do not include recommendations for balance exercise, which, I mean, we won't go there. There's no evidence in younger people, so we can't make guidelines, but I would probably recommend balance exercise for everyone. Anyway, the guidelines suggest all three of these things. Now, if your goal is fall or fracture prevention, you need to think about specificity. And if you have someone who is reluctant to start exercise, or trying to do all of those things might be challenging, and you want to start with something, you may need to prioritize muscle strengthening and balance and functional training if your goal is fall and fracture prevention, because that's where the evidence sits, right? The evidence is for those types of exercise and not for other types of moderate to vigorous aerobic physical activities for fall and fracture prevention. So we may need to prioritize the types of exercise we recommend as a starting point. And so we think about balance training. There's lots of different things that people do. They do things like rely less on a support object, shifting their weight while standing, moving their feet closer together, or go to one leg. But we need to also think about the importance of progression. And this is something as an exercise physiologist is fundamental, but may not be apparent to people in sort of clinical settings where like, well, you need to exercise, you need to do this type of exercise. We need a specific prescription. So how many times a week? What exactly should you be doing? And then how do you progress the exercise as you get better? And so every exercise plan should come with, once you get good at this, the next step is X, so that people understand that the goal is to continue to try to get better. And so, we can start with static balance exercises, but ideally we progress people to a dynamic exercise or something that's a bit more challenging. And this is especially true for people who have decent balance to begin with. So they may find, the basic balance exercise is quite easy to do, and it may not be sufficient to improve outcomes in this population. If we want to improve physical functioning, or if we want to improve bone mineral density, we may need to include resistance training, potentially in combination with impact exercise. We lose muscle as we age, and if we want to prevent that loss, or if we want to prevent the disability that occurs with aging, we need to train for it. And it's not that difficult to come up with a resistance training program if we think about it in terms of function. So in our daily life, we need to be able to push, we need to pull, we need to squat to get things, we need to be able to bend over to pick up our groceries, we need to be able to carry things, we need to be able to reach things or lift things overhead. So if we include one exercise for each one of these categories, and then just make sure that it is sufficiently challenging, and that we progress the intensity over time, and we do it twice a week, we will see benefits. Right? So you just want to make sure that you cover all muscle groups and think about how do we train to improve physical functioning. We may need to start using that messaging more. So it's not so much, resistance training because it's good for you. It's how do you, maintain physical functioning as you age. And so the idea is to train to make life easier. So I love this video from Dustin Jones, which kind of shows the parallels between many resistance training exercises, especially the functional ones like I mentioned, and the activities you do in daily life. So I'll just share this with you. That's a hinge exercise, that's a carry exercise. And then the step up, and then the lift up and press. And we get down to the floor again. Use that as an exercise. We do squatting. So just thinking about designing our exercises to support our physical functioning. And incidentally, the Liftmore trial that looked at effects of resistance and impact exercise on bone mineral density the resistance exercises were a squat, an overhead press, a bent over row, and a deadlift, all of which were demonstrated in this video that I just showed you. So functional exercises programs can work for improving functional function and likely might even increase bone mineral density. Oops. The second thing is thinking about safety during exercise. So not everybody can lift the amount of weight that woman lifted in that video I showed you. So it's not safe for everyone, especially not as a starting point. So we need to think about the risk versus harm. And in people with osteoporosis, you're often walking that line in terms of we want to progress the intensity to get the benefit, but we also want to do no harm. So we need to think about the types of movements that are likely to cause fractures. So one is falls. So doing things to prevent falls during exercise is paramount, but also spine sparing. So what are the types of movements that might increase the risk of a spine fracture? So one of them is twisting forces, especially when holding something heavy. So there are resistance exercises where you twist. So we want to make sure we modify those and make sure we use a step to turn so that the feet are facing the same direction as the torso. For some people, certain movements may outweigh the benefits. So this is where we need individualized recommendations. The other is bending and lifting at objects. So, teaching people to hinge at the hips rather than at the spine, keeping objects close to the body, and then even holding bags on either side so that they're balanced, as opposed to how many of you I know have, grabbed a bunch of groceries with one hand and your car keys in the other one. And what happens is that the weight of the groceries tends to bend your spine laterally. And so you have to use a lot of muscle forces to try to stand upright. Whereas if you divide the bags on either side, the muscle forces that you need are, the weights are balanced, you need less muscle forces. So it's less force on the spine. So, there's a number of safe movement tips we can consider for people with osteoporosis: bending at the hips, knees, and ankles, holding things close to the body, using a log roll and pushing with the arms to get out of bed, a step to turn, as I mentioned, using slow and controlled movements, and using seeking advice from an exercise professional or looking to Osteoporosis Canada for resources on movement. For people with spine fracture, we really have to use the best evidence we have, and otherwise start to establish some expert consensus so that we can design better studies to test new interventions. But we may need to tailor to the person. So the exercises I might give to a young person with one vertebral fracture, young-ish, like middle-aged, versus an 80-year-old who is falling and has multiple vertebral fractures and hyperkyphosis are going to be very different. In the acute stages, we want to avoid bed rest or limit it to 3 to 4 days. I would not advise bracing. I would avoid prolonged sitting and really focus on getting pain well managed with medication. As the pain gets better in the period between, the acute fracture and, roughly 12 weeks, when we would probably assume it would be healed, we can resume activities of daily leisure or daily living and leisure, potentially some exercises tolerated. Exercise targets should probably focus on form and range of motion and targeting back extensor muscles, shoulder stabilizers, leg strength and balance. We probably want to temporarily avoid any heavy physical exertion or lifting during the initial healing phase, and then progressively doing it as tolerated once the fracture is healed, obviously using common sense. So avoiding lifting heavy furniture or things that, probably the risk outweighs the benefit. Many people report things like difficulty with positioning. So problems sleeping is an issue. So you could lie flat on your back in the unloading position and use a bolster under the knees to sleep, and people may find that more comfortable. Anecdotally, my aunt had a vertebral fracture while we were working on this Delphi process, and that was one strategy I suggested to her, and she found it very helpful. So it's an anecdote, but it is something that can be helpful. Using the unloading position in general, lying flat, may be helpful for pain. And so coming soon, we'll have this consensus on non-pharmacologic management of osteoporotic vertebral fractures. I'm happy to share it with you, but look out for that. So now we're moving towards releasing the Osteoporosis Canada guidelines, and part of the process was taking the research questions, consulting patients on outcomes, and we had a patient advocate throughout the process designing the questions with us, determining the outcomes, working on the evidence to decision process to develop the guidelines where we considered the benefit versus harms, values acceptability, feasibility, and equity. And we hope in the new year we'll be able to work on dissemination, and we will consult patients on our communication and dissemination strategies. So I'm really excited about this and happy to present it, you know, when they emerge. But I will stop there and just highlight that we do have some social media places that you can look for more information as we do release the guidelines. You can learn more at Osteoporosis Canada's website, but the Bones Lab has a Facebook page, a YouTube channel, and I can be found on Twitter, where I tend to talk about all things osteoporosis. So I'll stop there and take some questions, but hopefully that was helpful. Thanks for inviting me.
Hey, and thank you very much. That was an amazing presentation. I love the slides; they're very nice and clean, and the video too. That was quite an amazing video to compare the exercises with everyday activities. And we definitely would like to have you back once the guidelines are out for sure. So we have a few questions, actually two from Nancy Salbach, and I'll start with those questions. The first one that she had was based on the slide that you had talking about the effects on bone mineral density. And she was asking what qualifies as impact exercise?
Yeah, that's a really good question. So basically we used ground reaction force and a sort of an established chart that like puts, you know, it says here's the activity and this is the ground reaction force. So we use the ground reaction forces to delineate as low, moderate, or high impact. And so impact exercise is anything where you have ground reaction forces, so running, jumping, even some forms of dancing, you know, and we basically categorize the type of impact. And so in the paper, we looked at all impact, and then we did subgroup analysis for type of impact when it was possible. So I will tell you that like walking studies, you know, we did in a separate paper. So walking would be considered impact exercise. It would be low impact. And there were maybe 2 studies of walking, and there was an effect, I think, on spine bone density, but again, it's really low or very low certainty evidence. The studies of impact exercise, so the Liftmore trial did show an effect on bone mineral density, but they were using fairly high impact exercise. So they started people just standing, for example, near a barbell on a rack, and they would just pull themselves up and then just slightly drop. So they kind of like a heel drop type exercise, and progressively increase the height the person would pull themselves up, and to the point where they were kind of doing drop jumps, which is a fairly high impact exercise. So I think from a patient implementation standpoint, if there was an interest in doing impact exercise, I mean, I would start with, you know, are they high risk? Because you're not doing high impact exercise in high risk people, especially not to start. But the idea of starting with something lower impact, like heel drops, or, you know, grapevine, or even starting with walking, they're not doing that, and then progressively increasing the impact. You know, obviously make good decisions around what is safe for that particular person. So I guess my short answer is the impact exercise can range from walking to drop jumps, and that's a source of the heterogeneity in the trials.
Nancy, does that answer your question? You can follow up with a related question if you like.
Yeah, no, that's great, because I was just wondering what was in that the scope of impact exercise, and that's expected in the literature, that there would be quite a range, and that's taken into account with the guidelines in terms of where do you start and how do you progress, and also tailoring to the person's level of ability.
Yeah, I mean, ultimately you have to tailor to ability regardless of what the evidence says. And there's going to be some people who are not going to be able to do higher impact. But we get people who have arthritis and they're like, you know, my doctor tells me I have to do impact exercise, but then I have knee arthritis as well and it hurts. So what do I do? Right. So in that person, I'm going to say, you know what, I'm going to leave the impact exercise right now out for now. We're going to focus on functional strengthening. And I might even push them a little higher intensity on the strengthening piece, because muscle pull on bone may be important for bone density. And it's actually hard to tease out whether the impact or the resistance is the one that's important. So, but I think, you know, there are some people who, the other thing that if you're going to do impact exercise, especially moderate or high impact exercise, you need to make sure your muscles are conditioned to be able to support that activity. So if you take someone who's not exercised and you start doing impact exercise, they will probably develop, tendonitis or some other problems because they don't have the conditioning to do it. So in anyone, I would always start with strength training before going to impact exercise. And you really need to make sure you have the fitness to do that level of high impact exercise, which is I think why they combined it in the Liftmore trial. It makes a lot more sense to kind of condition someone to be strong and to be able to withstand high forces in muscle before you start jumping and doing those sorts of things. So that would be my advice to people who are interested in impact exercises. Start with resistance training and progress from there.
Excellent. And actually, Nancy also had a second question, and I also have a question within that question. In terms of the mention of improvements in quality of life, when you were talking about quality of life, was that health-related quality of life? And I guess a similar question that I have is what sort of measures were typically used to measure the quality of life in those studies?
Yeah, great question. So it's health-related quality of life, and some of the studies use generic tools, and some of them use disease-specific tools, and some of them use both. So we did standardized mean difference because they all use different tools. The most commonly used disease-specific tool is the COLEFO tool. The other one would be, there's an osteoporosis patient questionnaire that's, I'm trying to remember the exact title of it, but there's another one that's still used, but I would say the COLEFO is used most commonly. And then the SF36 is used quite a bit, as well as a few other generic questionnaires. So we chose to do a standardized mean difference so that we could pool the findings, but certainly that, there is some heterogeneity in the types of questionnaires that we use, especially when you start combining generic and disease-specific questionnaires. So disease-specific ones frequently ask about back pain. Because back pain is, the concern that someone with an osteoporotic vertebral fracture might have. But a person with osteoporosis doesn't have a vertebral fracture, may not have back pain, may not score bad on that. The other thing, there's also heterogeneity in sources of back pain, so that creates an issue in those questionnaires. Whereas in the generic questions, don't specifically ask about back pain.
Excellent. Okay, very interesting, very interesting. So we do have another question on the chat from James, and he was wondering, when you mentioned earlier on about the multi-component exercises and that being a bit better than the other ones, what components consist of that multi-component exercise?
So multi-component exercise just means combining different modes of exercise. So mode is like the type of thing you do, like is it dancing and running or resistance training, balance training. So multi-component just means there's different modes of exercise. Frequently it's resistance training and aerobic or resistance training and impact. Or it could be an aerobic exercise that is also impact. So it's kind of complicated because there's also overlap, right? So a lot of the impact exercises that people use are also aerobic exercises, like running would be an example, or walking would be another one. So usually studies will combine resistance and aerobic or impact, or resistance with balance training. There's very few studies that look at balance training alone that don't have any resistance exercises or anything. There's very few impact don't do resistance training. And again, it kind of makes sense to condition people before you do impact exercise. Although there are studies of things like in postmenopausal women, there's a few more studies. So I didn't review that evidence. This was specifically in people. There's a lot of background noise. I'm not sure why that is, but sorry. We didn't look at the data in postmenopausal women because we wanted to focus our studies on people with low bone mass. There are some studies in postmenopausal women that suggest things like running and jumping may have an impact on bone mineral density. Multi-component programs, again, they tend to combine resistance exercise with impact or aerobic, or resistance with balance training. So those would be the most common combinations, or balance and functional plus resistance would be another common combination.
Okay, very good, James. I hope that answers your question. Feel free to unmute if you have a follow-up to that. If not, I'll have another question from Andrea. And she was wondering, where can we keep an eye out for the Fortify study, and will there be recruitment in Toronto?
So the answer to the second question is yes. So we're recruiting in Saskatoon, in Toronto, and in the Waterloo area. The recruitment in Toronto will be out of Toronto General, and the exercise intervention will be at Promotion Physiotherapy. Yes, there will be recruitment in Toronto. And then the second part question, where can we look for that information? So we will advertise our study on our Facebook page. So please follow our Bone Health and Exercise Science Facebook page, because I will share our guidelines and any knowledge dissemination tools there. I will also probably share it on Twitter. And we'll probably do some Facebook advertising as well. So yes, there will be, hopefully we will start in 2022. There will be a Toronto site, and yeah, follow us on socials. That'll be the best way to find out about it.
Excellent, thank you very much. So we are unfortunately running out of time, and I'm sure people have more questions. So do you have a few minutes to stick around after this? That sounds good. So I'd like to thank you once again to Lora Giangregorio for presenting such an interesting and engaging topic. And we look forward to the follow-up to see how the guidelines turn out. And I do want to say that these recordings, we will get them up at the KITE YouTube channel, as well as the Bone Health and Exercise Science Lab YouTube channel as well. So I thank everyone for joining us today, and everyone have a good afternoon. And our next lecture will be in January. Also, you can email Dr. Giangregorio. She put her email in the chat as well. So thank you very much, everyone.